Hi dents. This video will briefly cover the topic of dental caries. The tooth is made up of enamel, dentine, cementum and pulp. Enamel is a non-shedding surface which allows plaque to develop and grow uninterrupted. Plaque is a biofilm, which is a community of microorganisms and other components embedded in an extracellular matrix that adheres to the tooth surface. The caries process relies on plaque formation, but it's also dependent on other factors, which includes diet. So dietary fermentable carbohydrates like chocolate, or indeed acid in the diet, and also host factors, which include saliva, play a role. So saliva contains antibacterial agents that are protective against caries. So these include lysozyme, peroxidase, and lactoferrin. Enamel is arranged in enamel rods, and these are made up of hydroxyapatite crystals. The bacteria in plaque metabolize the carbohydrates and produce acid, lowering the oral pH. This dissolves the crystals, causing demineralization, and usually occurs at a pH below 5.5. Saliva then steps in to neutralize the acid, increase pH, and provide minerals that may allow the enamel to remineralize. Fluoride is included in this process and will produce fluoroapatite. A balance of demineralization and remineralization must be maintained to prevent the net loss of minerals. If demineralization outweighs remineralization, dental caries will occur. The Stefan curve highlights the change in oral pH over time after the presence of glucose, a carbohydrate. When plaque is exposed to fermentable carbs, the oral pH decreases rapidly, reaching a minimum by 5 to 10 minutes. Over the next 30 to 60 minutes, the pH gradually increases in order for oral cavity to recover from this acid attack. However, these times vary between individuals. This means that the frequency of carbohydrate exposure leads to slower recovery and longer periods of dangerously low pH, leading to a higher risk of caries, as seen in this graph. So there's different types of caries in the mouth. First of all, there's primary caries, which occur on non-restored tooth structure. Secondary caries or recurrent caries occur next to restorations that already exist. Residual caries are any caries that aren't removed before placing restoration. And rampant caries are multiple lesions that don't conform to the normal pattern of caries and can occur in the anterior facial surface of maxillary incisors. There's a difference in clinical appearance of active and inactive lesions. In enamel, active ones are white and rough, and in inactive enamel lesions, they're dark and smooth. Dentine active lesions are light brown and soft, and inactive are dark brown and hard. If the caries lesions remain active, it'll progress along the enamel rods and deeper until it reaches the dentine enamel junction, or the DEJ. At this point, the caries will spread laterally along the junction and further into the dentine eventually. It is usually described as an upside down mushroom shape on radiographs. As the caries progresses into the dentine, territory dentine will be laid down in the periphery of the caries lesion. This is due to pulpodentine reactions in response to the bacteria associated with the caries. Thus, the removal of the biofilm may lead to arresting the caries progression, but cleaning and removal of the biofilm may be impeded due to cavitation. Furthermore, the pH is much lower in cavities and makes the caries much worse. So thanks for watching, and please subscribe. Thank you.